So if you've got that tendon in a rotator muscle that you're repairing, is the repair always surgical with sutures? How difficult is that? How do you repair it?
That's a great question because that's actively changing. Most full thickness rotator cuff tears will fix. We'll repair the tendon directly to the bone. And again, we do that arthroscopically, which is a great benefit for the patient because there's less scarring. And I think the healing is just as reproducible when you're doing an arthroscopic cuff repair, if not better. But there are some partial rotator cuff tears that we can do something called PRP. It's called platelet-rich plasma.
Platelet-rich plasma, PRP.
Right. And we're just trying to figure out where we can apply this technology. What PRP is, it's your own blood that's centrifuged down to concentrate platelets, and with those platelets are going to be growth factors. And so it's a totally different injection than a cortisone injection. Cortisone is just an anti-inflammatory. Great for bursitis, great for inflammation. It's not going to help you build anything. It's not going to repair anything. PRP actually has the capability of enhancing healing. So we know that if we place that PRP when we're doing a cuff repair, it really doesn't change anything. But we've done several patients now, quite a few patients, where we just inject the PRP with ultrasound into the tear, into the partial tear, and have had some really good results. And so that's emerging. We're following that along. That's newer technology.
You mentioned that the recovery time and the success of rotator cuff is pretty good.
Yeah, rotator cuff repairs, especially now that we're doing them arthroscopically, the results are amazing. They really are amazing. So we can get in with just very small portals and repair the rotator cuff tissue back down to the bone. And there's various means of doing that, various anchors, various anchor configurations, and it allows us to more easily reconstruct the normal anatomy there. The recovery time varies based on what you have to deal with. So just like each rotator cuff tear is a little bit different, and I would manage 10 different patients with 10 different cuff tears differently. Different anchor configurations, we may do something with the biceps. It just depends on what you have. You also vary their therapy afterwards. So if we have someone that has a really large tear, tissue that may be a little weak because maybe they're a little bit older or maybe they've got some sort of autoimmune disease, you're not going to start them in therapy as quickly, right? Makes sense.
Sure.
But if you've got someone that has a smaller tear, a younger patient, you're going to start them in therapy more quickly because the construct that you achieve with a patient with a smaller tear, good bone, good tendon tissue, is going to be so much better than someone that's got a massive cuff tear that's got weaker tendon tissue. So you got to treat them differently. You got to be cognizant of that.
You know, the thing that I liked about what you said is every patient is different. There's no cookie cutter approach, and you've got to treat every patient according to really what happened to them.